Over the next 20 minutes, I'm going to talk to you about this clearly very important topic, but although important, it's an incredibly broad subject that I've been asked to cover, and impossible to cover in the 20 minutes that have been allocated. So what I've done is I've tried to select some key topics to cover and discuss, and of course anything that's in the review article that I haven't mentioned, I'm happy to discuss after the presentation. The other thing I wanted to highlight before I begin my talk is the evidence that's available out there is very broad, multiple definitions for dehydration, euhydration, and indeed overhydration, and different methodologies used. And as a result of that, the results that have been reported from various studies that have been conducted are somewhat inconsistent. I'm just going to give a brief background, then I'll discuss some conditions associated with dehydration, and then overhydration, and then I'll conclude at the end. Dehydration is important. It's linked with morbidity and mortality. There's a large multi-center study from the United States in older adults that reported a 17% 30-day mortality associated with a primary diagnosis of dehydration. They also reported a 50% one-year mortality, again associated with a primary diagnosis of dehydration. We know that a recent, well, not so recent now, but a heat wave that affected France in 2003 resulted in significant increases in mortality rate. In Paris, their mortality rate went up by 142%, with the most vulnerable groups at highest risk, and often the morbidity and mortality was related to heat-related illness, like dehydration. Overhydration is also linked to morbidity and mortality. We've heard about it most commonly as a result of iatrogenic fluid overload, and that's something that we come across a lot in surgical patients. But it's also been reported in healthy or seemingly healthy individuals like athletes, particularly in the context of hyponatremia. So I'll begin by talking about dehydration. There are many conditions or many systems that are reported to be affected by dehydration. Although I apologize for the small text, I just wanted to highlight there are many topics, and we will just focus on a few of those. I'm aware that we have a talk about renal pathology in the context of hydration, but urolithiasis, urinary tract infections, and bladder cancer have also been reported in the context of dehydration. The strongest evidence of this is in the context of urolithiasis. There's been one randomized controlled trial that looked at that. But urinary tract infection, again, there's some evidence linking dehydration to UTIs. And although there is evidence, it's inconsistent. But despite this, many physicians still recommend high fluid intake as a prophylactic measure for urinary tract infection, but also as an adjunct to conventional treatment. The NICE recommend, that's the National Institute of Health Research, recommend that, particularly in children that suffer urinary tract infections, that adequate hydration needs to be maintained. I won't talk too much about bladder cancer because of the time restrictions, but I'm happy to discuss that at the end. Gastrointestinal conditions, constipation, bowel cancer, and gallstones. I'll focus on the first two because that's where there's more evidence. With regards to gallstones, the evidence is largely associative. There's no real studies that have looked at a direct relationship. So with regards to constipation, it's thought that a state of dehydration results in increased fluid absorption from the stool, which leads to infrequent stool, and leads to hard stool, which is more difficult to pass. There's also a theory that suggests that dehydration results in reduced bowel transit time. Now, there was a study in healthy male volunteers where they were prescribed standardized nutrition and physical activity, and then they were randomized either receiving or restricted to half a liter of fluid per day for a week, or 2.5 litres per day for a week, and then they had a 2-week crossover and crossed over to the opposite arm. And what that study showed is that there was a significant reduction in stool weight and frequency during the period of fluid restriction, but it also showed that when the subjects returned to normal fluid habits, that resolved. So bowel habits returned to normal. There's also some evidence linking increased fluid consumption, particularly water, with reduced need for laxatives, particularly osmotic laxatives in children. There's also one study that demonstrated that increased water consumption results in increased activity or more effective activity of fibre in a diet. So they randomized 2 groups of people that suffer from functional constipation to a standardized high fibre diet, and then one group, group 1, they drank fluid as they would do normally, whereas group 2 were randomized to drinking a minimum of 2.1 litres of fluid per day, or roughly about 2 litres of fluid per day, and they demonstrated that you can see here significant differences in the stool frequency in that context. And the graph at the bottom here demonstrates that with increased fluid changes or increase in fluid consumption, there's increased in the stool frequency. With regards to colorectal cancer, it's thought that reduced bowel transit time and constipation is a major risk factor, and that's because it thought to increase the contact time with potential carcinogens with the bowel mucosa. And animal models have supported that, in rats in particular, where constipation and reduced bowel transit time was associated with neoplastic transformation of the bowel mucosa. There have been 3 main studies that I'm aware of, all case-control retrospective studies, and one particular study reported that those who said that they consumed an average of 5 glasses of water per day had a significant risk reduction of cancer compared to those who consumed 2. One study from Taiwan looked at the same thing. So the first study was from Seattle, and the relationship was mostly demonstrated in women, but there was no significant differences in men. This one here is from Taiwan, and they looked at the same thing. They looked at moderate, high and low fluid consumption, and they demonstrated that particularly with regards to lower cancers, which is particularly rectal cancer, there was a significant dose response, inverse dose response in relation to water consumption. So the more water the subjects reported to have consumed, that was associated with a reduced risk of cancer. And the relationship was most prominent in men but not women, and this is adjusted for various factors like age, BMI, and other known risk factors for colon cancer. I also highlight they didn't report anything significant in women. So just moving on now to cardiovascular disease, we know that dehydration results in increased plasma viscosity. We also know that increased plasma viscosity is a major risk factor for thrombogenic events or thrombogenesis in general. And people at risk are those with underlying, or particularly at risk, are those with underlying hematological disorders like myeloma and polycythemia, where they have a background risk of increased plasma viscosity anyway. Patients with sickle cell disease are also at increased risk of thrombogenic events in the context of dehydration. That's thought to be a slightly different mechanism, where dehydration is thought to result in increased red cell aggregation. And incidentally, one study demonstrated that normal erythrocytes, when dehydrated, also result in increased demonstrated adhesive properties similar to that seen in sickle cell. And for that reason, the theory is that patients that become dehydrated are at increased risk of thrombogenic events. There's been some papers or some studies that have linked deep vein thrombosis, cerebral infarction, and myocardial infarction with dehydration. In the case of DVT, there's only one real study that looked at this, and it looked at a group of patients that were admitted to hospital following an ischemic stroke. And basically what they demonstrated is that those who, the plasma osmolality within the first 2 days of admission of greater than 297, as well as a raised urea creatinine ratio, was associated with higher risks of deep vein thrombosis. With regards to cerebral infarct, the studies that have demonstrated that dehydration may be a risk factor in this condition, and basically there's only one real study that's looked at that, and this is from Tokyo, a group from Tokyo, many years back. They did post-mortem examinations in about 500 patients. About 100 of those had died from stroke. About 30 of those were from hemorrhagic stroke and 70 from ischemic stroke. And basically they looked at admission serum osmolality, they looked at admission hematocrit. And you can see here that the dotted line is those who have had a cerebral hemorrhage, the solid line is those who have had an infarct, and the hematocrit was significantly higher, or there's a greater proportion of those with ischemic stroke who have higher hematocrit. They then went on to look at those with ischemic stroke in more detail, and they looked at the atherosclerosis in the cerebral vessels. So the 2 pluses is severe, 1 plus is moderate, and this negative here is no atherosclerosis. And you can see here that again, there were a greater proportion of people with raised hematocrit that had severe atherosclerosis compared to moderate. And here there were none in this group here. Now, there's also some evidence to link dehydration with poor outcome in people who have had ischemic cerebral infarcts. So one study looked at basically osmolality as a marker of dehydration, that's serum osmolality, and they looked at outcomes. So they looked at 3 months mortality and function using the Barthel ADL, Activity of Daily Living Index. And what they demonstrated that dehydration was associated with poor outcome in these patients. It's not only mortality, but also the osmolality in the people that had functional disability was greater than those who didn't have any functional disability. And similarly with myocardial infarction, again, some evidence there. This is from, there's one main study really, it's called the Adventist Health Study, and they recruited adults who didn't have a background of cardiovascular disease, and they looked at looked at water and the rates of fatal cardiac events. And basically what they demonstrated is in this model here, which is adjusted for many things, including age, comorbidities, smoke and hypertension and so on, that in men, consumption of water, and I think they reported it is above 5 glasses on average per day, compared to less than 2, was associated with a relative risk reduction of this event. Another study also looked at myocardial infarction and demonstrated that dehydration on admission, as measured by plasma viscosity hematocrit and osmolality, was associated with poor outcome. Now, fluid overload. Fluid overload or overhydration is also important. I suppose in the world of sports science it may be called overhydration perhaps, but certainly in medicine it's fluid overload. It's been linked with morbidity and mortality in athletes. Some people have suggested that overhydration results in hyponatremia, but and obviously severe hyponatremia is associated with brain edema and mortality. However, I think we need to, before we can make that assumption, I think one needs to be clear on all the different factors that can influence that. It's not just water consumption. You've got to think about the rate of sodium loss, amongst other factors. With regards to iatrogenic fluid overload, it's really quite a big issue at the moment. Certainly it's improving, but in 1999, the UK Confidential Inquiry into Post-Operative Death highlighted that the most common avoidable cause of post-operative morbidity and mortality was fluid imbalance, in particular fluid overload. The morbidity and mortality associated with fluid overload is largely related to inadequate or wrong prescriptions. One study reported that some surgical patients received up to 5 litres of excess water and 500 millimoles of excess sodium and chloride. This can obviously predispose to heart failure, pulmonary edema, and even some studies have suggested renal impairment. It's associated with increased post-operative complications and increased length of hospital stay. A meta-analysis by one of my colleagues looked at all the randomized control trials that investigated intravenous fluid prescriptions in patients undergoing open, elective, major abdominal surgical procedures. And they highlighted that the key optimum is normovolemia. That's what we should all be aiming for. They also highlighted that with normovolemia, there is a 41% reduction in complications and the reduction in length of stay by 3.4 days. And this image demonstrates that. You can see that with hypervolemia, there's many complications. With hypovolemia, many complications also there, and the key is to try and be close to zero fluid balance. And from our experience, monitoring fluid input and output in all of our patients is the key to aiding adequate fluid prescription. I just picked a couple of systems just to focus on briefly, similar to what I did with dehydration. In surgery, the physiological response to surgery is salt and water retention. If you give people excess fluid, this results in edema, not only in the peripheries, but also in the gastrointestinal tract, in the myocardium, in the lungs. Increased abdominal edema has been shown to result in reduced blood flow in the splanchnic vessels, and it's also been reported in the context of even reduced renal blood flow. This results in prolonged post-operative ileus, which is gastric stasis, associated with morbidity. Some studies have also demonstrated that overprescribing of fluids results in swelling of the anastomosis, where the bowel has been resected and joined back together. Now, this edema can result in anastomotic dehiscence, which can be a life-threatening event. It really is a serious complication. DVTs have also been reported in the context of fluid overload. I have mentioned them briefly before in the context of dehydration. They're very common in surgical patients, and again, very important to be aware of the effects of overhydration on DVT. One study demonstrated that overhydration or hemodilution results in dysfunction or decreased activity of some anticoagulant factors like antithrombin 3, and obviously that predisposes to thrombogenesis. One study done many years back looked at patients undergoing elective major abdominal surgery. They randomized one group to receiving liberal intravenous fluid therapy before or after the operation. The other group received no intravenous fluids at all, and they demonstrated that within the fluid-restricted group, the prevalence of deep vein thrombosis was 7%, and in the liberal regime, the incidence was 30%. So significant differences. DVTs can result again in major morbidity. Now, before I conclude, I feel I ought to mention a really important topic of the impact of hydration status on drugs. We know that alteration in hydration status affects pharmacodynamics and pharmacokinetics. And in athletes, if we take them as an example, many athletes take drugs like non-steroidal anti-inflammatories for pain relief without full awareness of the possible potential renal complications. There was one study that looked at triathlon competitors, and they highlighted that 60% of those that were questioned consumed or took pain relief, NSAIDs for pain relief in the previous 3 months, and less than a third of those were aware of the renal complications or renal side effects. And some of those include hyponatremia. Another really important group of patients, perhaps ones suppose more relevant to me, are older adults. Many older adults obviously have comorbidities, but because of that, they're on many medications, including diuretics, and without adequate knowledge, and they take them really regimentally, regardless of any environmental change. And the kind of effects of that were highlighted following the heat wave in France in 2003 that I mentioned earlier. We talked about significant morbidity and mortality, particularly in the elderly group. But what was also reported is that the adverse drug events that were reported went up significantly, particularly those on diuretics and angiotensin-converting enzyme inhibitors were amongst the highest or most commonly reported adverse events. So in conclusion, there clearly is a growing body of evidence that highlights the importance of hydration status on health and links the state of fluid imbalance with disease. However, I feel I ought to highlight that a lot of the work is based on retrospective studies with methodologies that differ and potentially, that definitely need improvement. There's few randomized control trials. And one key aspect that needs to be addressed is the definition or an agreed definition of hydration, dehydration, or indeed overhydration, or even the way that we assess hydration status. Some studies have looked at urine output as a primary outcome. Others have looked at osmolalities. What is the correct way to go about this? And further work is desperately needed, I feel, to address some really quite key important aspects. So I just want to acknowledge the support and funding I received from the European Hydration Institute and Professor Dilip Lobo and Upinder Sahota for their contribution to the review. Thank you.
Thank you. Discussants are Ron and myself. I start? Okay. When I read your manuscript in preparation of this meeting, I felt I wanted to sort of step a little back and look at the whole picture. And what I felt is that actually, as you mentioned in your conclusion, we do not have evidence, solid evidence for the associations. And I was wondering, is this because there is no markers available, because the experimental design is poor, because there has not been a lot of interest in this area? What is your opinion? You looked at the studies.
Yeah.
Were you happy with the design, with the markers? What is going on?
To be frank, I lost quite a bit of respect for the published literature, having read quite a lot of things that I feel ought to have been...
Mean thing to say.
It shouldn't have been published. I think that there are key things to highlight. It's difficult. Okay? It's hard to go back and it's hard to do a study where you can pinpoint factors that predispose to colon cancer, for instance. It is hard. We've talked already about being able to quantify sodium intake. I suspect it's even harder to try and quantify water intake. We're asking people to do impossible things. But I think we have a responsibility as people who are interested in hydration and hydration-related research to make it clear that, or at least try and highlight some guidelines for people to try and use in future research. I think that's something that needs to be clarified. There's also lots of inconsistency, and I think the inconsistency is related to two factors. One is the reliability on methods that are not reliable, like recall of fluid consumption, for instance. The other thing is about people using different markers. So in the case of urolithiasis or renal stones, there's one randomized trial that randomized people who have had a previous history of at least one stone to either increase fluid consumption so that they produce at least 2 liters of urine per day, compared to people who are normal fluid habits, and they demonstrated significant improvements with that regime. So that, I feel that was a nice, clear measure of hydration. So we've talked a lot about fluid balance, and I think the urine output is a good way to do it. Some studies, like the things we talked about with DVT and the cerebral infarcts, took serum osmolality. It's very difficult. What point do you take that?
Following out on what you have been saying, I was wondering whether a document like a scientific opinion document on how to look at these things would be of help. And I recall that, for example, in nutrition, we have documents like this for how to measure antioxidant status, for example. And EFSA has issued scientific opinion on how to measure cardiovascular disease, on how to measure appetite and weight control. And I was wondering whether you think that a scientific opinion document on how to measure hydration status would be of help for the scientific community, like something that we could agree maybe.
No, I definitely feel that that's something that's desperately needed, not only for scientific research, but to aid clinical diagnosis and management of hydration. Yeah, it's certainly needed.
Also, another thing that occurred to me is that there are a lot of acute and chronic disease that are mentioned in your talk. If you would like to, let's say, set research priorities, would you pinpoint to some of them, and your criteria would be public health concerns or available evidence, for example? Would you go to cardiovascular disease, which is a number one, or hypertension? Would you go to something that there is evidence, or?
It's a very difficult question. I think all conditions are important. I think if that's key. But I think we need to take a step back, and once we've agreed what the guidelines are for assessing hydration status and what appropriate methodology should be used, I think yes, I think we should start with areas where in current practice many clinicians and many expert committees recommend increased or decreased, in some cases, fluid consumption, or highlight them as risk factors or as beneficial for some conditions. So what worries me is some guidelines recommend things without much evidence base, and I think that's probably a good place to start, because that's currently what clinicians are prescribing or working to.
Professor Kunarek from Zagreb is a gastroenterologist, and he has some questions based on his perspective, and you will find he's interesting as someone who works with surgical patients, because one of his questions says, how can we protect patients from ignorance regarding water intake, because surgeons push patients to drink water ad lib?
Okay. I think
it comes back to the overhydration.
Well, let me be clear with one thing. I don't think there's any evidence linking overconsumption, oral consumption of fluid with overload in our patients. The reason our patients are overloaded, it's because we haven't got, or we have better knowledge now, but we certainly are not knowledgeable enough on what we're prescribing and how much we're prescribing. Professor Lober did a study some years back and looking at knowledge of the most commonly prescribed drug in the hospital, which is IV fluids. And you'd be surprised that a significant proportion, I can't remember the exact figures, but certainly less than half of consultants and junior trainees were aware of what was in it. The other thing is, until recently, a lot of people use normal saline, and that's been shown to be quite detrimental to various systems and certainly contributes to edema. So I think the problem isn't oral. In fact, we should always encourage our patients to drink orally so we can avoid intravenous fluid therapy. And in the change in practice is kind of leading people to encourage oral intake very soon after surgery.
I spent 3 years working in the surgery department, so nothing surprises me anymore. But we went through that 30 years ago, John. We looked at giving oral fluids in surgical patients versus giving IV, because the default was IV at that time. The patients tolerated the oral fluids very well. They were very happy with them. They didn't have the complications you get from IV. But the nursing staff didn't like it, because if it's oral, it's a nursing staff responsibility. If it's IV, it's a medical staff responsibility. So the doctors were very happy with oral intake. The nursing staff made it impossible for that to continue.
Yeah.
How do you resolve that?
I think knowledge, again, it's just knowledge and awareness. The culture has changed. We are, particularly in our unit, there's real clear guidelines. Where we can, we encourage people to drink as soon as they can after surgery. Some years back, the advice was to keep people nil by mouth to allow the gut to rest. That's all been shown to not to be the best advice now. So yes, it's a multidisciplinary effort that needs to be shown some leadership, but I think knowledge and awareness is the key aspect. If we can show nurses that if you give patients oral fluids early rather than IV, they'll do better, they'll go home quicker, they'll make it a priority. Yeah.
So the default should be oral.
That absolutely. That always is the default at the moment, unless you need to replace certain electrolytes, certainly. But in our units anyway, if they can consume oral fluids or eat and drink, that's what we should do.
I was just going to ask you to clarify. That's the default in your unit. Is it recognized nationally and internationally as the default?
After the surgery, the way of drinking, especially abdominal surgery, you go intravenously always at the beginning. I don't agree with you that it's the prescription that is the problem. It's the balance that is the problem, because they prescribe, but they don't look for the output, and they don't monitor clinical signs of hydration. That's the point. It's lack of attention, lack of supervision, because you can prescribe 5 liters a day after the surgery, but then you have to see what's going on, if it is going out or not. If not, you need to react. That's basic.
I think, I don't know, I'm not sure I totally agree with that. I think what has been shown, I'm not an expert in it, there's a term called enhanced recovery after surgery. And what the evidence shows that if you can get people to normal eating and drinking habits, even after bowel surgery, they always do better. The problem is, if you start prescribing people at default intravenous fluids, you're open to all the problems that you get with that. Not only is it the fluids, and there's a cannula in place and associated complications to that. So we find that if you can get people to eat and drink, and I'm sure there are national and international guidelines that recommend this, it's always better for the patient, providing they're absorbing enough fluids.
Yeah, and then there's a reason why they don't go to this level. They probably don't recover. They don't recover very well from the surgery. This is why they do not start eating and drinking after the surgery, after the short period. First, you need to start the peristalsis to work. That's it. The intestine don't work. You don't give any fluid, anything orally. So if they don't recover because of complications, because of infection, whatever, you cannot go. And these people really have worse prognosis. That's obvious. This is something that you have to take into account. And if you put everybody into the same box and you mix them up, you have very difficult to interpret results. That's exactly what is the problem. One of the problems in literature. They put everybody together. They don't look for the differences, and then they take the conclusions, as you mentioned, as prescription. It's not. It's the balance and the lack of supervision.
Potentially, I think in some cases that's the case, but I think there's been a cultural change in surgery, and it's not just in our units; it's across the country, and it really is to try and encourage people to if they can, if their gut is functioning, to get them to eat and drink. The two reasons for that is they do. It's been shown they do better. They absorb the right things, and you don't overload them not only with fluid, but also the concern is the sodium and particularly the chloride that you get with intravenous fluid therapy.
The chlorides do not give you that much problems with these amounts infused, because maybe some acidosis, but very small hyperchloremic acidosis can result out of it. But normally, with the amounts you prescribe in the surgical units, you can't get that far with overloading with chlorides, especially because there's a lot of fluid lost during the surgery, and then you replace it, and it's a short-time treatment normally. The problem is when it is prolonged, then you are right, it can be a problem, but normally it's not that much.
Yeah, I was just going to ask, you say there's a lot of fluid lost in surgery. How much? How much fluid is lost in surgery? And if it's blood that's lost, it's blood that should be replaced.
You can count it by hour.
How much?
Yeah, I will not give you at the moment, but it depends very much on the type of surgery. General surgery is usually 3-4 liters in the first day has to be replaced. It's the minimum.
I think there may be some differences in different countries. If you look at Dilip Lobo's study, he's an upper GI surgeon. He's my colleague and professor of surgery in Nottingham. If you look at his study that was published in The Lancet, I think, on fluid restriction perioperatively, they minimized sodium chloride infusion. The patients left 3.5 days earlier, but we measured gastric emptying on them as soon as they were mobile, and their gastric emptying returned to normal very quickly post-operatively, even though it was GI surgery. Whereas the ones who had standard treatment, their stomachs remained inert and did not empty for about 5 days.
And this is the key thing.
So this is the key thing, that they must not be overhydrated. And it wasn't balancing intake against urinary loss, it was restricting intake, restricting fluid infusion.
But I think just to add to that, I think in this recent meta-analysis, although Prof. Lobo labelled this in his study as restricted, and in this field, the same issue of definition applied, what they did is, when they reviewed the literature, some people called it restricted, but actually when they look back, apparently it was normovolemia. That was what we're aiming for. Or it was called restricted because it didn't give people lots of fluid, but it was normovolemia. And just to add to what you said about the chloride, just a recent study that was done from our unit, where Professor Lobo led, they looked at healthy volunteers, MRI functional scans of renal perfusion, and they compared normal saline to plasma light, which normal saline has a higher chloride concentration compared to plasma light, and they showed there was impaired renal perfusion in patients in the subjects rather that received the normal saline because of the or related to the hyperchloremic acidosis, although mild.
I'm just asking, where does 3 to 5 liters a day, where does it go? That's an enormous volume of fluid.
Yeah.
Where's it going?
First of all, into the intestines that are paralyzed. The third spacing is called. And you need to replace it. It's still water in the body, but in the wrong part of the body. It's inside the intestines that are paralyzed after the surgery. Same happens in pancreatitis. Out of the blue, the weight is the same. It's water shift into the third space.
I mean, I agree, there is change, there is third space changes of fluid distribution, but the body of evidence demonstrates that normovolemia in surgical patients is what we aim for. The surgical trauma results in fluid and salt absorption anyway. That's normal physiological response to surgery. So the key is to normovolemia, monitor input and output and address that. That is the key message at the moment.
But we are talking volemia or hydration. They are two separate things.
So
volemia is the blood volume. Hydration is the water in the body.
yes. So we judge that, but
the same thing. You can lose 1 liter of blood, and this is clearly hypovolemia. And if you lose 1 liter of sweat, it's also 1 liter, but completely different fluid.
sure.
So the impact on the cardiovascular system is completely different.
I agree, but
Hypovolemia is one thing, hydration is another thing. Separate.
so we measure the hypovolemia by, as I said, fluid balance by input and output. So presumably we can agree, I suppose, that if the kidneys are being perfused, there's adequate hydration, adequate blood volume, and as long as the patients are producing enough urine, then you can be satisfied that they're adequately hydrated. The key is not to give them too much fluid.
Give them to keep them hydrated 7 liters of water and you get 6 liters of urine, the kidneys are functioning probably very well, not necessarily, because this can be the specific kind of acute kidney injury, polyalcohol. Okay. So it's tough. So you can't put everyone into one box and say, oh, everybody behaves like this. You have to individualize and look really, because bulimia and hydration at the same time. Yeah, completely different symptoms and completely different signs of both, and you're going to be not to mix them, because most of the problems in clinical setting comes from mixing up hydration and bulimia. Severe dehydration comes with some hypobulimia, that's true, but you can't mix them. You have to be very careful. If you mix them, you make mistakes, obviously.
Ron, would you like to continue with...
I have another question on a slightly different topic from Professor Kunarek. So if someone wants to continue on this topic, I don't need a microphone. I'm wearing one. And his question was about constipation, and there are certainly a lot of epidemiological studies showing an association. What about intervention studies showing that improving hydration, looking at functional outcomes, and how do those compare with intervention studies looking at probiotics or prebiotics as treatments? Do you know?
I don't know anything about the pre and probiotics, but what I can tell you is that increased water intake has been shown to be beneficial in two ways. One, from the study I highlighted here, that it's shown to increase the effects of high fiber diet. We know that high fiber diet helps improve constipation, and increased water intake has been shown from this study to help with that. In kids and in adults, it's also been shown that increased water consumption reduces the need or the use of osmotic laxatives.
But no evidence that you're aware of in relation to the use of pre or probiotics?
I can't comment on that. Something I'm not aware of, sorry.
I think perhaps you can open the discussion more widely.
Ibrahim, okay.
Yeah, I'd like to go back shortly to the question of postoperative fluid management. And I completely agree, Ahmed, that normovolemia is a key question, but you shortly mentioned hyponatremia, the risk of brain edema. And I think this is a second key point to avoid, because in the early 90s, considerable morbidity and mortality was described also in children in the first 12 postoperative hours. And that's why we propose and we use, and I think in the UK this is similar, 20% restrictive fluid management in the first 12 hours. And we do it with an isotonic, a high sodium solution with balanced fluid, so with a low chloride concentration to avoid metabolic acidosis. And I think this is very important for brain edema. And this is this postoperative risk of hypervolemia and hyponatremia due to a non-osmotic activation of antidiuretic hormone. And this is one of the situations what Larry mentioned as when the system doesn't work properly. So what could we do to see if the ADH is still highly effective? We should monitor not only the input and output, but the specific gravity or osmolality of the urine. And to measure the specific gravity is very simple with a stick. So we can do it every 3 to 6 hours. And this is a simple method. And after 12 hours, we see that now the urine is not so concentrated. So so one more factor to output, input, the specific gravity or osmolality of urine.
When I first started doing my research, the first thing I wanted to do is invent a urometer that had an osmolality measure on it, but somebody already beaten me to it. They've patented it, but it's not used in clinical practice. So the idea would be, what we do currently is monitor hourly urine output in select patients, and we feel that's a very sensitive marker of the hydration status, fluid balance, in quotation mark. But I think that I do agree with you. I feel there needs to be an additional marker and something that amalgamates hourly urometer that monitors or measures your hourly urine output with osmolality. I think could be something to be introduced. I agree with that.
So when the osmolality goes down, or the specific goes down, that's the moment where my doctors they deteriorate the fluid management.
Yeah.
Until then, 80% restriction.
Yeah, I totally agree with you.
Thank you, Ahmed. Shouldn't we think of the tonicity when we talk about dehydration and hyperhydration? So we learned there is isotonic dehydration, hypotonic and hypertonic, so the different forms of dehydration. It is not only one.
I totally agree. And when I wrote my review, my first paragraph in the introduction is exactly that. It's to highlight, well, actually it's the second paragraph. It's to highlight salt balance. You can't just take dehydration, broadly speaking, just like that. And this is again one of the problems that we face from the literature. That there isn't a standardized method to assess, or in fact, the methods are there, but people don't report those factors in their studies. So we've talked about weight loss as a measure of dehydration. We've talked about osmolalities, but in the context of salt and fluid balance, balance as well, that needs to be reported. Yes.
I need to learn more about the impact of medication on the regulation mechanism of water and electrolyte household.
Okay, so there are two things to highlight, and we've got some renal experts here that I'm sure can add to this. The first thing is to consider, the first point that you highlighted is salt balance, so dehydration in the context of salt balance. The other is the impact of dehydration on other organs, particularly the kidney. So if we take, if somebody's on lithium, it's a drug that's prescribed for mental health disorders, bipolar disorder, and you take somebody on diuretics. So some diuretics result in salt loss, obviously sodium loss. So if you combine diuretics or somebody on lithium, or if somebody on lithium becomes particularly dehydrated and that affects their kidney function, I think, if I remember rightly, lithium can be absorbed through the sodium channels, if I remember rightly. I don't know if anyone can add to that. So if you're on lithium and you become quite dehydrated, I suspect there's a risk of becoming, getting high serum lithium concentrations, and that's quite detrimental. Does that?
And that is taken into account, so in
well,
regime?
so it's taken into account in the context. You should never prescribe diuretics and thiazide diuretics in particular with lithium. But what I was trying to highlight is, for me, it's not necessarily people that are on lithium or drugs like that have a very narrow therapeutic range. What I want to highlight is just people on diuretics. I think what people need to be aware of is that when you're on diuretics, if you're dehydrated or it's really hot or have a massive heat wave, you've got to consider whether it's appropriate to continue taking those diuretics. And obviously that has to be considered in the context of why they're on the diuretics. So I just think there needs to be better education. I wonder if you can add to that.
Well, I just want to add really to the last point you were making. One of the big drivers which increases risk for acute kidney injury is clearly an episode of dehydration, so you go and get diarrhea and vomiting. But when it occurs in people who are taking a diuretic, which many old people are for a good reason, or a non-steroidal, or an ACE inhibitor, then you compound your risk. And so one of the health education messages is helping people to understand that if they're on those medications and they get diarrhea, they just stop the tablets for a few days. And that would be an extraordinarily powerful way of avoiding avoid it. It's a health safety thing. You'll stop people coming into hospital.
And again, that's the biggest problem, I think. I think we don't, as clinicians, offer enough advice with those drugs. I think they're seen as relatively safe, and because of that, advice isn't always offered. And some patients, I suppose not all, but some patients really are meticulous about taking their medication, and they'll take them no matter what. So we need to educate ourselves as clinicians, but obviously educate patients as well.
Thank you. Maybe it's only a comment regarding another time the group of population, because as you're working in gastrointestinal, in cardiovascular, it's possible to define the different studies, which group of population, and more or less in the review also specify
Sure.
what kind of range of dehydration or chronic dehydration. As you were talking, there is not clear definition what means that. In each study is considered different values, but should be a way to define something that could be accepted?
Can you just speak? So I didn't quite get that, the question.
To create a consensus regarding what is chronic dehydration in this, from these studies, is possible to take any kind of a consensus regarding that or no?
So of all the studies overall, you mean? Yeah. I think the key thing, I think, as I mentioned before, we need to do more work. I think it's only in very few categories where randomized trials have been performed that I feel you can take the results and interpret them properly. The vast majority of the literature is associative, and because of that, you don't know what's the cause and what the effect is. You can make a guess, but you can't be sure. But also, as Larry alluded to before, if you look at osmolalities, urine osmolalities of different populations, they're different. And you can't just do urine osmolality on a population and decide that that group are dehydrated and link them with certain conditions. It's very difficult. But I think if we can agree a consensus that further work is needed, or guidelines need to be established in a way to assess and conduct hydration-related research, particularly in the context of ill health, that'd be a positive step forward.
Most of what I see in the advice that's given to people suggests that it's better to err on the side of a little bit too much than a little bit too little water, because the kidney will cope perfectly well, and as long as you drink enough, the kidney will get rid of any excess. So the studies that have appeared in the last year or two suggesting that chronic overhydration may be associated with increased risk of osteoporosis, for example, are somewhat alarming to someone who's looked at that advice and said, yeah, that's probably sound advice. How good are those studies?
I think that it comes back to the original point that we made several times, is you can't apply one advice to everybody. There are people at higher risk than others. But what I would say is that various studies have looked at that, particularly in the context of hyponatremia. If you look at people who have psychogenic polydipsia, they're a group, again, that studies people that just drink lots of water for no apparent reason. And there is a risk of osteoporosis in that group. So I think if you want to provide sound evidence or advice rather to the public, it needs to be evidence-based. And I don't think we can just say, just drink liberally. I think there are health consequences of that. I think we need to do the right work, do the work and present the right evidence so we can give good advice. Otherwise, people just won't listen.
But one of the problems is people do listen to some of the advice. If it's advice that they find congenial, they'll follow it. So when I type into Google, how much should I drink? In the UK, the first website that comes up is some water website, and it says drink more. It doesn't say how much are you currently drinking. It just says drink more. Yeah.
So I think that's dangerous advice. I don't think that's the right way to go about it. We'd be falling into the same trap as some of the published literature.
So I think we need to balance the two, don't we? Too
Yes.
much is not good and too little is not good.
There's one study that said, well, several studies that apparently report, if you look at bladder cancer, several studies tell you that if you drink water, more water you drink, the higher the risk of bladder cancer. So, you can't just report things like that without qualifying them. I think we need to be clear.
And I think the problem is also that the public sort of, as Ron says, they choose the bits they want to hear, but they also misinterpret the bits they do hear as well. Yeah. So If you remember, a couple of years ago, there were some deaths of patients on VLCDs, the advice for which was 3 litres of water a day, so they thought 6 would probably be a better idea. At a time when you're only consuming 500 calories a day and you've got serious negative balance of most things, that was not a good idea, and it killed a couple of them, which wasn't my point. But there were 2 points which were separate. The first is, I'd be careful with your slides, because the slide said decreased transit time, but you didn't mean that.
Did I write? Is that what I wrote?
It said decreased transit time. You meant decreased transit.
Yeah, transit, yes.
So that you slowed transit time. It was longer transit time. So you need to be careful.
Yeah, decreased transit, yes.
Yeah, the other thing is the sort of frail, vulnerable, older patients that I think are probably more concerned about here. And the difficulty in knowing whether the sort of impairment of cognitive function that they might be showing is just was there anyway, is a consequence of a change in hydration status or a change in electrolyte status.
Of course, yeah.
And you know, sodium levels will have a big impact.
Yeah.
So from your reading of the literature, has anybody tried to dissect the water from the sort of sodium in those sorts of patients?
Not in those. So there's only one study that I'm aware of that looked at delirium. And it looked at delirium in long-term care residents. And they looked at water consumption in the context of that, and they said that, they reported that with every glass of water consumed per day, the risk of delirium reduced by 33%. That's what they reported. Again, it's an association rather than a solid evidence. But I have to say that cognitive function in the context of dehydration or hydration status and electrolyte balance in the elderly is not been looked at. What we do know is that sodium imbalance in the elderly is associated with cognitive impairment, and it's incredibly common, mainly driven by medication that they take, and a big proportion of those are a consequence of diuretic and antihypertensive drugs.
I have a question regarding obstipation, and I think you showed one slide with stool frequency increased with drinking more than 5 glasses of water. Yes. I think so. Do you remember the correlation with it? Because I thought it was very weak.
It is a weak. I think it was a weak correlation. I remember the values. I can look those up. And you're talking about.
Sorry for.
It's all right. You're talking about. One second.
Oh.
I'll get to it. Many slides.
This one.
Yes, I don't actually remember the correlation, but certainly I can look that up for you. But if you look at stool frequency and look at the table at the top, it gives you better figures here. So this is the number of stool.
It's per week, or isn't it?
This is per week, yeah. So you can see the differences pre-trial and post-trial, and the change, and all these are statistically significant.
Okay.
I don't know what the correlation is with the graph. No,
anyway, I was wondering because they I think the group just regarding more water intake or 5 glasses of water and not total water intake or beverages, different beverages. So why do they just choose water?
So why did I just choose water? That's a very good question. And I have to say that's something that I think is a positive thing from the studies. I think when you do a study, you need to be clear with what question you're trying to answer. If they looked at total fluid consumption, there are lots of studies that consider things in coffee, tea, and alcohol to be carcinogenic or have potential carcinogenic effects. So I think if they looked at total body water, that may give conflicting results. And in fact, indeed, that's what happened with some of the literature looking at fluid consumption and bladder cancer. Many studies looked at various fluids as well as water consumption, and the results are sometimes difficult to interpret because there are criticisms where people, talk about confounding effects of coffee and tea and things like that.
Or milk or fruit juice, so it's water. So the water intake is there. So if I don't drink water, but I drink a lot of water by drinking milk, I have also a high water intake.
Sure. I think they're two separate questions that we need to answer. I don't think the right thing to do is to necessarily, and certainly not in all cases anyway, I don't think you should amalgamate the two questions. But yes, it's a clear point. Any other questions?
I have one. I was reading in your manuscript, you have very interesting information about water and pregnancy and breastfeeding. Would you like to talk a little bit more about that?
Okay, so I think I had to report that. I know nothing about that field, but I had to report that in my review because I really felt that there's a lot to be learned from some of the studies that were designed and reported here. We had randomized control trials that looked at, in pregnancy, looked at oligohydramnios. And one study looked at fluid restriction of 100 mils over a period of 4 hours, I believe, and oral consumption of 2 liters of fluid, and they demonstrated that clearly that there was an increase in the amniotic fluid index, or the amniotic fluid volume, by 16% in those that consumed the 2 liters of water. That was 4 hours later. And in the fluid restricted group, or the ones that only had 100 mils of water, 4 hours later, there was a reduction in the amniotic fluid index by 8%. So that was a nice study. Others have also looked at intravenous fluid therapy to try and treat people who have oligohydramnios, and they've looked at water orally, intravenous fluids, isotonic and hypertonic solutions, and they've demonstrated that 2 liters of water increases the amniotic fluid index quite clearly and quite neatly, I feel. Regarding labour, I think the question is outdated because some years back there was fear of allowing women to drink or eat and drink during labour because in case they needed an anaesthetic or a general anaesthetic. We don't do that very often. People, if they need an operation, they often have a spinal, so the risk of aspiration is less. So women are allowed to eat and drink. So basically the studies that have been done looking into IV fluids with labour, basically what they demonstrated is if you were allowed to eat and drink as normal, or liberally, and then you were prescribed faster rates of intravenous fluids, they gave 250 mils an hour compared to 125 mils an hour of isotonic intravenous fluid. Basically, they found there were no differences. If you were starved, then you're not allowed to eat or drink, then you get the faster rates of fluid, then there is kind of an impact on the progression of labour. So they looked at particularly at prolonged duration of labour and need for oxytocin in patients who have been induced. Does that make sense? It's a complex topic. With regards to breastfeeding, I'll briefly mention there's been a couple of studies which both reported that maternal hydration doesn't impact on the quality or quantity of breast milk produced, but they are limited studies. But I do know that EFSA recommend that you should consume, if you're breastfeeding, consume 600 to 700 mils of water extra per day to the normal women, what women consume. Sorry, is that...
Okay, when you look at the modern textbooks of internal medicine,
yeah,
you will see half of it is about infectious diseases, the other is autoimmunological diseases. And there are some papers now, quite recently, dealing with hydration, not really hydration, but hypertonicity and high sodium intake, and autoimmunological diseases, saying, okay, you need hypertonic solution to stimulate lymphocytes, and the majority of problems we have with autoimmunological diseases comes from increased sodium consumption and not enough water consumption, of hypertonicity of internal milieu. So did you read anything about this and to share with us?
Yeah, sure. What I can say is that I certainly am not an expert in immunology, but I can say the literature alluded to something which I thought was quite neat. If you look at patients with upper urinary tract infections, so that basically pyelonephritis, there's some studies that have demonstrated that increased fluid consumption improves your outcome, because not only low osmolality helps the function of the immune cells. So that's one reason. The other thing is the kind of dilution effect, or the flushing effect. So higher osmolality is thought to be may impede the effects of your immune cells. So again, an interesting dimension, but I suspect it may be discussed later.
You've focused obviously on the title of your talk, which was on adverse outcomes related to inappropriate hydration. And we talked a little bit about adequate intakes. And of course, by definition, the adequate intake is the amount typically consumed by people who are in good health, i.e. who are free from those unwanted outcomes. And one thing that's always confused me is when I'm in Europe, it seems my adequate intake is 2.5 litres a day. But if I go to North America, it's 3.7 litres a day as an adult male. So when I fly into Vegas to play the tables at the weekend, should I drink 50% more than I do when I'm at home?
May I clarify what it is that you're drinking and how much it costs?
They don't specify. They say water.
Is it cheaper in...
Well, they just say this is the adequate intake for water. It's 3.7 litres a day, I think, in the US, and it's 2.5 litres a day in Europe.
Basically, I'm sure there is some evidence supporting these recommendations, and I don't think I'm qualified to comment on that. But what I just feel from my interpretation of the literature that there really isn't that strong body of evidence available at the moment that we can go back to be able to recommend a certain amount of fluid. And I also feel that we shouldn't necessarily recommend a certain amount of fluid intake to everybody. I mean, we live in a world where technology is becoming a part of day-to-day life, and I don't know why we can't try and categorize the population into groups, not just the young and the old, but perhaps people who are very active, people who are not very active, obese people, and then people can just follow the guidelines and take what's appropriate to them. I think we need to approach this in a fresh light and kind of move on. I think a lot of the definitions are from the 70s, maybe even before that. I think we need to update our definitions.
These are definitions from the 2000s. These are relatively recent statements. And if this is indeed the average amount consumed by healthy people, and it's 50% higher in the US than it is in Europe, we should see different patterns of disease. So what are the epidemiologists doing about those things?
We have different calcium recommendations and different protein recommendations.
We're not here to discuss calcium. We're here to discuss water.
We look at the same evidence, and the American version is different to the European
I mean,
version.
even within our continent, I think in Europe, we talked about the normal urine osmolality of the German cohort that was studied as 800. People in Finland, I think, had that much lower. I think there isn't such a thing as one fits all. We have to get away from that. And that's what I mean by a fresh approach. We need to re-look at the topic with new pair of eyes and try and do, kind of produce guidelines that really do match the evidence.
But the physiology of Americans is not so different. They're sort of humanoid. It just seems a remarkable difference, a 50% difference in something as basic as water.
All I say is, I think you should look at the evidence that they base this on. That's all I'd say, and I think that that's all I'd say.
Is there any evidence on what you should drink, or it is only observational?
Oh, this is observational.
So it's not evidence.
No, well, you may say it's not evidence, but if indeed there are associations between the amount people drink and health outcomes, then there should be, and if that's what the average person in the US is drinking who's staying healthy, and in Europe the average person is drinking a third less and staying healthy, you might expect to see some differences in disease patterns. And I don't know if there are any.
Then we have to talk about what does it mean staying healthy.
Some decision is more precautionary.
But it shouldn't be precautionary because it's not a recommended amount. It's an observation of what people do.
You ought to also, as I say, you ought to wonder. I mean, also they drink different things generally. I think that may be we've already seen that people drink different quantities of different things. I think it's a difficult one. I don't have an answer for it.
Becoming healthier is one of the reasons we broke away from our British.
It didn't work, did it? It didn't work.
I believe in his recent book, Tim Noakes made some sort of quote that goes along the lines of, thirst is the only consequence of dehydration. Obviously, he's making this statement in relation to healthy individuals, but in your reading, do you feel that that statement is valid?
In a word, no. There's been a lot of publicity recently, I feel, in the recent past anyway, about question people's motives for investigating hydration and outcome. But I think all I can say from my reading of the literature and my knowledge, and I'm sure again renal colleagues can add to this, we know that dehydration can be detrimental. In the elder adult groups, I know he's talking about healthy individuals, but in older populations it's associated with morbidity and mortality. I don't think you can make such a statement, and I think that's entirely wrong. I feel that the potential serious consequences, potentially life-threatening in association with dehydration, not only in old adults, but I'm sure in healthy individuals. But I don't know if any of the renal colleagues can add to this about the spectrum between dehydration and acute kidney impairment or acute kidney injury. But I mean, in the context of acute kidney injury, of dehydration, it's a spectrum, isn't it, from my understanding? Yeah. So severe dehydration will lead to acute kidney injury.
Degree, number of factors.
Yeah.
Well, he's trying to sell books as well as, so statements like that help sell books, I think.
He also says that's true up to 10% dehydration.
Okay.
That there are no health outcomes.
Yeah, this is the problem. The literature has, it's supposedly peer-reviewed, but there's lots of things that are published that, as I say, are questionable.
I have also a question.
Sure.
Most of these diseases have a lot of factors that influence the development of the disease. Do you consider any of those to be mostly associated with water intake? I mean, in which ones do you think water intake is the determinant factor? Is there any, or?
So there are no studies that have looked at people with certain conditions, if I understand the question correctly, so that people that have a condition and then become dehydrated and the progression of that condition. Is that what you mean?
I mean that if you look, for example, cardiovascular disease, you may say that fat intake is the most important determinant, if you can say that, or calcium intake for osteoporosis. Do you think that there is a number of diseases that mostly associated with water intake?
No, basically from the literature, there's no evidence to support that argument. Again, from my personal view, and I'm sure our renal colleagues can add to that, the only condition that I can really, that I'm aware of where there is a real strong link between dehydration and impairment of and the condition is some forms of acute kidney injury. In the case of oligohydramnios, I mentioned in pregnant women, there is some evidence that dehydration does reduce the amniotic fluid volume, so that's something to consider, but that is not the only factor, or that is certainly not the main factor that predisposes to that condition.
Are there other questions? No. So as we move towards finishing your presentation, I would like you to summarize first for which of the diseases we have evidence, strong evidence that water plays a role.
I think probably just oligohydramnios, maybe urolithiasis. I think basically that's as far as you can, and even then you're really pushing it out to say there is really solid evidence to support those two conditions.
On the other hand, we have a number of situations that we have recommendations without solid evidence, such as breastfeeding and constipation.
So breastfeeding, the EFSA guidelines, National Institute of Health Research talk about increased fluid consumption in kids. There's the European Society of Urologists, I think, recommend increased fluid consumption to help with people who have got a history of urolithiasis. Constipation, general advice from clinicians. There are many, many guidelines. I think the reason those guidelines have been, I don't know, I'm not involved in those societies and have not helped produce the guidelines, but I do feel that there may be the notion that, drinking a little bit more water is not going to harm you, therefore let's recommend it. But I feel the evidence isn't there to support those recommendations in most cases, and I think the key message is further work is needed.
And then we have some major public health issues such as cardiovascular disease, hypertension or stroke that we do not have evidence or recommendations. But
Yeah.
we do have mechanisms that we think that are involved.
Yeah, I think so. I think that one of the problems is in some circles, hydration is not really seen as a really important topic. So we know for a fact that, well, one of the treatments for people that have severe hematological conditions like myeloma or where they increased plasma viscosity, one of the treatment is to give intravenous fluid therapy to help dilute that. But I think there's a lot of things done without solid evidence, but we just take them for granted as you know, they work and they're essential.
Is there any other comment? So what would be your last sentence to that?
What I'd say is we need to do more work. Just quite frankly, there isn't really much more to say than the evidence is lacking. I think we, as I said before, we have a responsibility to highlight the appropriate methodology appropriate for this type of work, appropriate methodology to assess dehydration, a minimum standard, if you like. And certainly we need to highlight that a lot of these conditions need to be further investigated in the context of dehydration.
Thank you.
Thanks.